Thank you all. We'll move on to the next speaker. It's my pleasure to invite Dr. Sachin Kedar, who's Professor of Ophthalmology and Neurology at Emory. His talk is going to be My Vision Fades Out, Visual Disturbances from Migraine.
Good afternoon, everybody, and thank you to the organizers for inviting me to this subspecialty conference today. I have no conflicts of interest to disclose. The goal of today's talk is to discuss the differential diagnosis for a patient that presents with transient visual disturbances, especially in a patient with migraine. And since these are common in the community, all of us will have these patients in our clinical practice. So I'll start with a patient that I recently saw in clinic. This is a 30-year-old young patient with a 2-year history of visual disturbances. She has a past medical history and a family history that is strongly positive for migraines. 2 years ago, she started a new job, which increased her stress levels, and she's noted that there has been an increase in severity and frequency of these episodes. She also tells me that she hears a heartbeat in her ear during these episodes. This is the key of the issue. You always have to ask them details of these visual disturbances. What do they mean by it? So this patient tells me that she has this vague blurring of vision, and then her vision pixelates out, which means dot by dot, it just disappears over 3 to 4 minutes, stays dark for about 10 to 15 minutes, and then it slowly pixelates back over 3 to 4 minutes. The whole episode lasts for about 20 to 25 minutes. During these episodes, she has managed to cover one eye, and she figures out that it is only one eye at a time. Occasionally, these episodes are triggered when she stands up, but what she has also noted that most of these episodes are followed by a dull pain around her orbit and the head, which lasts for about 1 to 2 hours. So when I examine her in clinic, it's completely normal. This includes visual functions, visual fields, fundus photos, OCTs, and even tomographic sections through the macula, which does not show any evidence of recurrent ischemic episodes. So at this time, in this age group, the most likely cause for the visual disturbances is an aura from a migraine. But what I want you as an ophthalmologist to recognize is that this is a diagnosis of exclusion, and it is important to document a normal examination in between the episodes. What are the other possibilities? The other possibilities are cerebral ischemia, occipital seizures, retinal diseases, and papilledema from high ICP. Patients with cerebral ischemia will describe an abrupt onset of vision loss, and depending upon where the localization is, it can be a hemianopic kind of a visual field defect. Typically, the episodes will last for about 60 minutes or so, and then in some patients it will persist, and in others, if it's a TIA or a transient ischemic attack, it will resolve. Occipital seizures, on the other hand, have an abrupt onset and offset. And remember, the occipital lobe has no way of formed visual hallucinations. So these people will have unformed visual hallucinations in the form of geometric shapes, pinwheels, circles, it could be multicolored, monochromatic, lasts for less than a minute, never more than 5 minutes, and it's usually localized to one hemifield depending upon the localization of the lesion. They may or may not have altered sensorium, and they may or may not have automatism, so don't rely on that. Retinal diseases, especially in a patient who says, I see a curtain-like effect coming down on my visual field. Remember, retinal traction can cause lots of positive visual phenomena like flashing lights. Retinitis can do it, retinal ischemia can do it. And of course, patients with papilledema can have transient visual disturbances with postural changes when their vision blacks out for a few seconds and then it comes back. So everything is in the details of these episodes. So our patient had another episode where she had slurred vision for 15 minutes, where she went to the ER because her colleagues were worried about a stroke. She had a full stroke workup, and that was all normal. So the diagnosis is migraine with visual aura. It is very common. 1 in every 5 individuals, 1 in 5 women, and 1 in 10 men will have migraine. And of these individuals, a third will have some form of aura, and more than 90% of these aura are visual in nature. The classical aura in migraine is that scintillating scotoma right in the center of the visual field, which then gradually spreads outwards in a whirl fashion, forming the fortification spectra. Patients can have positive phenomenon or negative phenomenon where they have loss of vision, but usually patients will perceive it in one eye despite the fact that the pathophysiology is a spreading cortical depression. Less common presentations of visual aura in migraine are perceptual. Patients can describe kaleidoscopic or a cracked glass appearance. They can have multiple images. They can have persistent images called palinopsia. And about 15% of patients will have Alice in Wonderland effect, where they will see images being distorted, either bigger, smaller, further, or closer than they are. And then there is this phenomenon of visual snow, where everything in the background appears to be pixelated with fine dots like snow. It is important to observe these patients with visual aura because they have a higher incidence of cardiovascular disease, particularly those who are smokers, those with diabetes, the perimenopausal women with hot flashes, and those on hormone replacement or estrogen therapy. There is an increased odds of developing major cardiovascular diseases in this population. This is a take-home slide, one of the take-home slides. These are the red flags for your patients with migraine. So a patient can have migraine, but they can also have some other pathology. Always look carefully at your patients who are older. If your patient presents with an aura above the age of 50 years, it is not migraine. Think of something else. Patients with risk factors for cerebrovascular disease, patients with a history of epilepsy, traumatic brain injury, a family history of epilepsy, or other kind of neurological insults, it's more likely to be a seizure than anything else. Patients who have a side-locked aura or headache, which means it occurs 100% of the times on the same side. In migraines, patients will often come and say, well, it happens on the right side, but if you press them, they say, yeah, 10% of the time it also happens on the left side. Abrupt onset and offset can indicate either ischemia or seizures. If it's persistent, which means lasts more than 60 minutes, think stroke. If they have a unilateral or a bilateral hemianopic pattern that persists after the event, think of a structural pathology. A curtain-like effect and presence of altered sensorium or automatisms. So remember, when you see these patients, you document a normal neuroophthalmic examination, which includes a normal ophthalmic examination. There is really no treatment for these auras at this time, and most of the therapies for migraines are geared towards headache. There is some limited data that lamotrigine may actually help these patients. So partner with your neurology friends. They will rely on a normal examination from you prior to initiating therapy. So thank you for your attention, and if you have any questions, I think we'll take it after the next talk, right?